introduce our speaker. After graduating from high school in Jonesboro, Arkansas, Dr. Blackburn pursued a BS in psychology at BYU in Provo, Utah in 2003. After graduating, she worked for 4.5 years in an HIV research lab at the University of Pennsylvania before deciding to pivot and pursue a career in dentistry. Dr. Blackburn attended Columbia University College of Dental Medicine in New York City, graduating in 2012. She did her pediatric dental residency at Yale New Haven Hospital in New Haven, Connecticut from 2012 to 2014. She bought her practice, Growing Great Grins Pediatric Dentistry, in 2017, where she currently practices. And Dr. Blackburn purchased her first laser in June 2017, just before purchasing her practice. She's been on her laser journey since then, and we're excited to hear from you today, Dr. Blackburn. With that, I will hand it over to you to start tonight's lecture. So take it away.
Hello, party people. Okay, so we are talking about no-shot dentistry, how you can enhance really everyone's life, your team, you, your patients, everyone, with your amazing laser. So I'm going to be talking from a perspective of, you haven't used your laser as much, but don't worry, there's going to be plenty in there if you have been using your laser a ton and you just want to expand your field. So my motto today is going to be, try not, do, or do not. There is no try. So you can do it. Don't worry. All right. So first, who am I? Who's this? Who's this? Joe did a great job introducing me, so I'll blaze through some of this. So first, I'm a wife. I'm a mom, I'm a pet owner, I'm all these things. So I'm a real person in addition to being a dentist, like all of us. So, going forwards. I'm also a boss. So like you said, I brought my practice back in 2017. This is some of my awesome crew. They are amazing and I love them. And they are really a huge part of my talk today because they're a big part of what makes everything happen. So then I also love monster trucks because who doesn't? Hello. I tell people I was not born to drive a monster truck. I was born to flip a monster truck. Yes, I was. I love reading. That's my husband and I bought a beach house this last October. So that is us at our beach house, just chilling with our kids reading. And I also love geology because I'm a nerd. You'll see. Don't worry. Hey, so blah, blah, blah. He went to school, blah, blah, practice. Isn't it pretty? It's pretty, right? And then disclosure. So BILAS does give me an honorarium. I don't think so for the webinar. I don't remember. Doesn't matter. But other than that, the only people that pay me are my patients' parents and occasionally my patients. Yes, I am that pediatric dentist that doesn't kick people out. Yeah. So what are we doing here? What are we doing this webinar? What's going on? My goal for you. I want you guys to identify times where you could avoid local anesthesia if you're not doing that as completely as you want to. Figure out how you can work that avoidance of local anesthesia to your advantage clinically, and then also from a business sense, and then begin the creation of a plan to attract patients who value what you're trying to offer. So don't worry, I'll give you examples and stuff. First, what if I told you that with this laser, you would have to learn to identify patients in your morning meeting that might need local anesthesia? Otherwise, your team just won't have it out. I know what you're thinking. You're thinking, for real? For real, really. That is true. And it's happened to me where I forget to identify, oh gosh, this patient, I've seen them before, or this certain type of tooth we'll talk about, maybe I might need local, and it just won't be there. And then I'm like, oh, hey, I need to give local. And my team is like, okay, the needles are over here, and here's the carpules, because they don't have it out. So to shot or not to shot? Oh, wait, please, no shot, please. Situations in which you can try to avoid local anesthesia. So most of the time in my practice and a lot of heavy BILAS users that I've spoken with, you can avoid local anesthesia in restorative situations, such as these. Don't worry, we will talk more in depth. So basically fillings, hypoplastic teeth, crowns on baby teeth, crowns on big people teeth, veneers. I'm going to pop in a little bit of adult dentistry, even though that stuff is kind of gross and scary. But don't worry, I'm not going to try to speak as an expert because clearly I don't do that. I'm a pediatric dentist. But also soft tissue procedures, not only the ones we think about. When we talk about laser and we talk about soft tissue, everybody wants to go frenectomy. Everybody's like, frenectomy. Okay, well, there's other things we can do too. So of course the frenectomies, also gingivectomies, and especially if you're doing very slight, sometimes you don't even have to do any type of local anything, you just do topical, concentrated topical, important point. Packing cord, I know people say it's crazy, but I swear I've done it with not even topical. I just use certain settings, I'll go over it, kind of all around the gingiva, and then pack that cord, and kiddo's okay, and they don't have to be numb after. So then endodontics, ew, I really don't like it, except for pulpotomies. I like pulpotomies, those are fun. The rest of it is gross, and I don't like it. Pulpectomies, I will do if you put a gun to my head. The RCTs, ew, no, I don't do it. Some people are like, well, do you do anteriors? No, but that's great if you do. You should do that. It is very possible to do it with a laser and without having to do traditional local anesthesia. So now, how would I be doing this? Anybody who's talked to me in a training type of setting knows that I totally jive with laser physics. It's like my jam, because I feel like if you understand the machine, that's where you can understand how to manipulate the settings to make it work in various situations. So as you look at the machine, you have watts. That's your power. So big, I know. Then you have hertz. That's the frequency at which the power is being delivered. So you can think of it, this is how I explain it. You can think of it as the power being cut into chunks. So like at 75 hertz, it's cut into littler chunks. So the power per punch, the power per fire of that little segmented power delivery is less than at 20 hertz, because you're cutting it into into more chunks at 75 versus 20, where you're cutting it into fewer chunks. Hope that makes sense. Then the water. So water is keeping heat away. That's a huge thing it's doing. Absorbing laser energy, as does the hydroxyapatite. We'll talk about that in a sec. And then the water streaming from the handpiece, it's crossing at about 1 to 5 millimeters from the tip. So the water is also showing you your active zone. Okay. So then the air, working with the water, making it flow, getting it off the tooth, all these beautiful things. Okay, so then the mode, H versus S mode. That's how long the individual pulses contained in that overall power punch last. So with H mode, it's shorter pulses, meaning that you have less heat building. And then S mode, longer pulses, that's more heat building. So you're going to see most of your restorative settings are going to be in H mode, and most of your soft tissue, you're going to have an H mode that's like your quick, dirty, go get it done. Then you're going to have an S mode that's a little bit prettier. That's the stuff that has more heat, so it's going to go cut smooth like that. Okay, so wait, what does that mean? Oh, I don't like it. She had the girl over here, like, yeah, she has like a what face. So what does that mean? Sorry, I clicked on that. There we go. Okay, it's how the laser effects change. So how the laser effects change is by explosive thermomechanical ablation. Do we feel smart? I feel smart. Basically, it works by delivering joules of energy to the area of concern, whether that be the tooth or the soft tissue. The joules build up there until you have, for numbing, a high enough concentration of photons that it causes a laser analgesia. The mechanism is putative. If you want to hear my theory on the take from what people have put out, you can ask me, but we don't have to talk about it. It's putative. For tooth ablation, the photons seek out water molecules or hydroxyapatite. The energy builds up until the photons become unstable, and it goes pew in a really small way. So it's those explosions that actually cause the tooth structure ablation. For soft tissue removal, they're seeking out those water molecules in the soft tissue, and pew, 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 and water molecules from the water, and pew, 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 pew. See, like that, pew, pew. So yes, now put it all together. So hard tissue. When you're getting people, kids or adults, numb, you need to deliver a certain amount of energy, those joules, to the center of the tooth to achieve that effect. So knowing how that works, you know you need to deliver this amount of joules, right, to that area. So to get the energy there, you can modify the power and the other settings to make it happen in different ways. So knowing how the laser functions can help you make those adjustments on the fly. So that, and we'll go over scenarios so that you can be like, well, that's not working there. How could I change it so it does work? So for example, you feel like a patient is feeling it as you're trying to numb them. So maybe you started the machine at the standard 4 to 5 watt power and 15 to 20 hertz, right? The factory settings. So if you turn the power up, say to 6 watts, and the frequency up to say to like 75 hertz, you're cutting that power into smaller chunks. So you're not hitting it as hard. You can think of it that way, right? It's not going like bam, bam. It's like tap, 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 tap. But you turned the power up. So the amount of joules that you're delivering per time increment is going to be similar. See what I'm saying? Yeah, you got it. You got it. Don't be intimidated. You can do it. And by turning the power up, again, you're delivering that same amount of joules in the relative same amount of time. Or sometimes if they're starting to feel that, what could you do? Okay, you want to deliver fewer joules to for that time period, right then. Back it up. Back it up. You're a little bit out of that effective working zone, so you have fewer photons being effectively delivered to the center of your tooth. Soft tissue. Soft tissue, the more joules that you're delivering to the tissue, the greater the heat buildup and the tissue removal. So you're doing a procedure, let's call it a maxillary frenectomy, and it's taking forever. You're like, I did this like 2 minutes ago. Why is this not working? So rather than getting frustrated, maybe you turn the hertz down. Turn the hertz down so that you're cutting that power into fewer bundles so you have more power per punch, right? So you achieve greater cutting speed. Or you turn that watts up, but incrementally. Soft tissue, you don't want to jump it from like a 4 watt to a 6 watt, right? You're like 2.75 or something. You want to go like 3.25, like that. And then turn that power up and see if that gets you the cutting speed that you want without causing additional uchis. So basically, don't be afraid to mess with the settings. You can do it. Okay, so if that sounds intimidating, don't worry. So ready? Let's go over common clinical situations. How can you modify on the fly and achieve avoiding the local for more patients? So standard situations, I broke it into pedo and permanent and soft tissue. So here we go. Pedo, class 1 and 2 fillings. Just do it. Just do it. So I tend to use slightly different settings than the factory settings. Both can work very well. It's just really what you prefer. If you are interested in the settings that I use, because you like my blah, blah, you can always message me, message BioLays. They'll give you my contact info. I had it there at the beginning, but message me and I'll send you what I use. I have a document because I do training, so I have it already written up. For comfort prep, I do 6 watts, 75 hertz, blah, 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 blah. And what I do, because as the BioLays representative, you should use that tip one time. I don't. Most of us that do it, we don't. It's like really expensive. So what I do is based on the age of the tip that I'm using, it's really going to take me a different amount of time to be able to do what I want to do. So what I look for is if I'm doing about the same working length and I'm doing it at the same power settings that I always use, I look for enamel demineralization. I look for frosting, you know, like you etch that junk for like, I don't know, like 45 seconds or something, you know, like it's getting that little bit of frosting. So what I found clinically is that when I start to see that frosting, that tends to correlate to when the patient is comfortable. So then even if I'm using an older tip, I can still be able to see when it's being effective. And for me personally, how I know that the tip is bad is either the sound goes down. If you use the laser enough, you know, sometimes you listen and you're like, that ain't right. That ain't right. So either that or I'm doing it and I can hear it working, but oh my dear gosh, it is taking me too long to numb this tooth. Then I say, okay, ladies, this tip is no good anymore. Let's get it out for the next patient. And they do that. So then rapid prep, I do 6 watts, 20 hertz, H mode, blah, 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 those things there. And I love it. It works great for me. You should do that. It's awesome. For pedo teeth, for class 3, 4, 5 fillings can be trickier. These suckers like to be sensitive because that stuff is really thin, that enamel. So the rule is to go slower So it's what I do, we would call like the modified turtle technique. So turtle technique would be start really low and then move it up very incrementally. Hair technique, fast rabbits, is high power, low hertz. And what you do is start high and go down low. Both were great. Modified turtle, I'm starting at a little bit less of a delivery, that high power, but the high frequency. But it's going to take less time than the actual turtle. So it's modified turtle. So with class 3, 4, 5 fillings, I do actual turtle. So I start at 1 watts, 30 hertz for about 10 seconds. One of the patient populations I'm going to talk about here in a bit when we get to that is going to be very tiny children. So like my 2 to 3-year-olds, when I'm doing this in op with them, I break it into 10 seconds because usually they have about 10 to 30 second attention spans, depending on the kid. So I'll count to 10 while I'm doing each one of these. And I'll go, let's count to 10. And we all count as I'm like, go, 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 go. And then at 10, we're like, yay. Oh, you did so good. Okay, then turn it up to 0.25 watts at the same hertz. And then I go, let's count to 10 again. 1, 2, and I go, 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 go. And I keep doing that until I get all the way to 2.25. And at 2.25, I do it at 2.25 and 30 hertz for 10 seconds. And then I turn it down to 20 or 15 hertz. And that's my cutting. That's when I'm doing it. So usually what I'll do with the small children is I'll then say, okay, now we're going to count to 20. So big. Okay, can we do it? They're like, yeah. I'm like, okay. And I start cutting. Then crowns. So I get this a lot when I talk at trainings and stuff. People are like, for reals? You're really going to do a crown with no local? And their eyes say like, you can tell me. You can tell me you don't really, do you? And I'm like, yeah, I do. Yeah, I do. Not to every patient, which is what we're going to talk about. But what you're thinking about is really when you're pointing the laser, it's very focal, meaning that it's just going to numb where you point. So if you're not pointing to the whole tooth, it is not going to numb the whole tooth. But honestly, just be smart about this. Like, where is the pulp, right? So you just kind of have to go over where the pulp is. Like if you were all the way over on the edge of the marginal ridge and like on the edge of the buccal, like, dude, is there pulp there? There's really not. So what I do is I make sure I cover that whole pulpal area and get the whole pulp all numbed up and stuff. And then I'll do like a quick, like 5-second pass on the rest of it just to make myself feel good about it. Whole pulpal area, little unbuckle, little wingle, make myself feel good. That doesn't work for every kiddo. So this is not every single crown you ever do is going to be no local. How I do it, you guys can play with it. I encourage you, play with it. The worst thing that's going to happen is a kid feels something and they don't like it. And they're like, oh my goodness, I'm so sorry. But you know what? We're going to blow Mr. Sleepy Bubble and you'll be okay. So as I excavate decay, if I have a kiddo that's showing me with their eyes that this is tough for them, that it's just a little tough for them. So what the example I classically use is when I'm doing like a really deep DO. You know, you're doing L, you're doing S, and you've got a huge DO that's turning into a pulpal and a crown, right? So when I do that, as I'm going kind of sub G, you know it goes sub G. As I'm going kind of sub G, removing the decay, if I have a kiddo that's just kind of like, you know, they're watching Paw Patrol, things are happening, everything's fine. I'm like, okay, this kid got it, right? I can go no local on them, they'll be fine. If I have a kid that as I'm going right there and I get the slow speed, and we know you hit the gingiva with a slow speed, right? We all try not to, but you're gonna bump it a little bit, that's okay. As I bump it, if I see that kid's body tense and I see their eyes kind of go like that, that's not necessarily a kid I'd want to go no local on, because probably me fitting that crown sub G, not going to end in happiness for all of us. So if I see them not loving that, to me, that's a kid that's not going to tolerate those sensations. And I go ahead and anesthetize, because we don't want to, you know, I think some of us that are laser users, you can fall into the trap of like making local your enemy. Like, I hate you, local. No, to me, what the BioLase, the WaterLase does is let you use it as like a tool in your toolkit. Right? You don't have to have it out for everybody, but you use it judiciously when you really need it and think it would benefit the patient. So then pulpotomies and pulpectomies. So really, I just do the same thing that I do for the crowns that I just talked about. And yes, it totally does work. Most of the time when I'm doing it, when I'm doing those big old DOs I was just talking about, I will actually enter the pulp before I give local. Not intentionally, it's just usually as I'm excavating. I have electronic handpieces, so I'll have the speed way down at like 1800. And I'm like, go, be so gentle, don't go in the, oh crap, there's red. And I'll be like, is it red? Are we sure, Leslie? Do a little, that's red. I should do a pulp. There we go. So usually I'm in the pulp by the time I end up going, okay, it's going to be a crown. This is a kid that was flinching from before. So let me go ahead and anesthetize. But even those nervous kids, they're not feeling it. So you can do it. So same criteria as the crowns. I always follow those up with the crowns, of course. I think most of us, we don't do fillings over the top of pulpotomies and pulpectomies. So if a kiddo could do it, I just make sure that I've thoroughly gone over the whole tooth, just like I said before. All right, cool. So common issues with pedo teeth. These are the things when they're going wrong, when it's not doing what I want it to do. So I was thinking through issues and what happens and what I do with them. These are the ones I came up with. So zingers, when you have a kid that you watch their eyeballs and their eyeballs are like, ugh. Now, most of the time, it's not super dramatic. It's not like the kid's like, oh, it hurts. No, they're just like, ooh, that feels weird. And then I always stop and go, hey, everything okay? Thumbs up, thumbs down, because I have ice light in their mouth. And if they're like, it's weird. Okay, so if you're using the settings that machine comes with, doing that kind of hair technique, if you're starting high and moving down, occasionally they're going to feel something. So sometimes they just feel something, but I found more of my people that I train that they're going to feel a little bit if you're not used to it and you're going down too fast. So what do? You're starting off too close, back off a little bit and see if that resolves it. And by a little bit, I mean, we're talking like, a fraction of a millimeter, how you quarter of a millimeter, half of a millimeter, back it up just a little bit, and see if that resolves it. You might be staying in the same place too long. So I tell people I draw circles like this. I told this one girl this, felt so bad. I told her I draw little circles. When I went to actually go to her office and train, she was going like that. I was like, oh, sweetie, too big. Yeah, too big. My fault. That was my fault. Bad communication. So it's just like little tiny, like I feel like I'm drawing little tiny spirals. So you want to be continuously moving because you think through what's causing the pain. If you're delivering too many joules of energy there too quickly, they're going to feel it. So then you can turn the hertz up. So if you're right there, if you want to turn the hertz up, okay, that's going to be less power per punch. They have less chance of feeling each of those punches. It will take slightly longer unless you want to turn that power up too. Okay, so another reason for a zinger is that you moved outside the area that you did. So like I just talked about, especially for me, class ones, a lot of class ones. Sometimes, we're all judging. We're like, oh, I think it's going to be about this big, right? And so sometimes when I do that, I've learned over time to be like, am I getting close to that margin? I should just stop and redo comfort prep. Or because you've moved outside the zone of safety. So then what do? You go back over the areas and you extend the zone. That's it. So another common issue with small children is noise. For me, it's about once a year. About once a year, I have a kid that despite doing tell, show, do, we'll talk a lot more about how I have my team do that, but despite good tell, show, do at the beginning of the appointment, they just like you go to put it in their mouth and they're like, oh, it's so loud, right? I have noise canceling headphones in my office, so I'll offer that to them. Do you want to wear these just while I use that loud? We call it our airplane noise for the comfort prep, and then our popcorn popper for the rapid prep. Do you want to use it while I use that guy? And they're like, yeah. I'm like, cool. If they're like, no, and then I tried to do it and they're like, then I go, okay. For numbing, what you can do is you can turn the power and the hertz down some. So if you go from 6 to 4, so you're lowering the power. So if you keep the hertz the same, it's going to take you way longer, right? But if you lower that hertz as well, as you lower the power, try it on your laser when you get done with this and you're there tomorrow. It's going to make that sound a lot softer. So if you lower the hertz, yes, it's a little bit louder, but it's a lot softer than it was. So then again, you can deliver the same amount of joules to the center of the tooth, but in a way that hopefully they will find better to their ears. For prepping, you can turn the power down and then the hertz way down. So if I'm going from 6 watts to 4.5 watts, I'm going to do 10 or 12 hertz. Get really a lot of power for that punch so I can still take away tooth structure. But that can work if they just don't like the noise. So then slow prepping, if you feel like it's taking forever, most commonly because maybe you're using that tip until it's really, really done. Then just turn the hertz down. That's what I do if I'm intra-op and I know I'm not going to use that tip again, but I have it on there right now and I don't want to make the patient wait that whole time while I change it. I'm at 20 hertz. I'll turn it down to like 15 or 12. And then I'll still get power for my punch, and then I can chuck the tip afterwards. But you should totally not do that one-time use, right? Yeah. Okay, so then hypoplastic or hypomineralized teeth. So we all know those suckers be hard to numb, right? I feel like you could have like a whole day's griping session about this. So what I do when I'm approaching these teeth is I get a baseline first. So when I'm talking to the kiddo, I know this is a hypoplastic or hypomineralized tooth. What I do is I show them on another tooth. I say, and I'm like, okay, see how that feels? They're like, uh-huh. And then I go over to that tooth and I don't just rely on their verbal report. I watch their body, right? So I'm going, do they go, whoa? Is their face going, oh, that hurts, right? Or are they like, totally fine, and they're like, I kind of felt something different. And then if it's that, then I will say, and so if I can watch their body and their voice tell me that it feels bad, I stop and anesthetize. If their body says they're fine and their voice says, yeah, it was a little different, I say, well, you know what? Either I could blow a sleepy bubble and it could make your tooth go totally numb so it doesn't feel too cold, or it's going to feel cold for about 10 seconds. What would you like to do? And then I let them choose and go with how they feel. So even if I do anesthetize, this has been huge for me because we all know some of those kids that you pump local in and they're still feeling one stupid spot. So what I do is I do the local and then I also do laser analgesia. That to me has cut my hypoplastic zingers to almost zero. Super love it. I have this one kid I worked on today, actually. He has amelogenesis imperfecta. Oh, type 1. Oh, so I've had to rebuild his mouth several times and all permanent teeth. And with that, he used to have some zingers. Now that I've done that dual approach for the last couple of years, no zingers. He's all good. So for kiddos with sensitivity, so if you just have a hypoplastic tooth, has no decay or anything, so you're not doing restorative, it just hurts. This is what I use. So I do this setting for 30 seconds. This setting, so it's, you'll notice, pretty much the same, except you turn the hertz down for 30 seconds. And if I'm doing whole tooth, I'll go whole tooth. And I just kind of draw over and then I modify that 30 seconds just a bit up because I'm doing a larger area. This protocol was created for like class 5s on older people, but it works great for hypoplastic teeth. And then you do the same hertz, same mode, turn the air and water off, defocus, means that you come back and you got to move fast, or else you're not only going to have them feel it, you're going to burn. So you got to move fast. And if at any of those points you have sensitivity, go back to that previous step until they don't have sensitivity. Okay, I really like that protocol though, if you want to write it down. If you don't get to it, email me, I will email you. Okay. So standard situations for permanent teeth. So class 1 fillings, they can take a little bit longer, and it makes total sense when you think through science because more mineralized. So there you go. So it can take a little longer, but once I see that frosting, go for it. Class 2, what I found when I first started doing this is I was getting a heck ton of zingers in the box, like so many. And I was like, what the frick? My partner, so much so, she's now retired, but so much so that that I bought my practice from, she worked for me for 5 years. She was like, screw this. I'm not doing this for permanent interproximals. I'm just not doing it. But I was like, I can do it. I just have to figure it out. So what I do is I do the same comfort prep that I always do, and I do it the same way until I get the frosting. Then I do rapid prep. I cut half the box. So if this is my box, I cut to here. Then I stop. I redo comfort prep just in the box for about 20, 30 seconds, not that long. I put 20, 30, I don't really know. I just do it till I feel like I don't see them, like, because when I first started doing comfort prep, a lot of them, I watched their eyes go. So they're not telling me it hurts. They're not like, ooh, zinger, none of that, but I can see they can maybe feel it a little bit. So I do it until I watch their eyes go relax, and then they're fine. So then I do rapid prep. So then I cut down just a little bit more before prepping as normal. I think pretty much all of the real big water laser users that I've met, we do that hybrid where we do laser and then we do traditional hand pieces and we go back to laser. Okay, so class 3, 4, and 5, same as baby teeth, nothing any different. So then crowns, veneers, and other fun adult things that happen other places that are not with me. Okay, so obviously I don't do these, so I don't have like huge pearls of wisdom, but from my experience of baby teeth crowns and hypoplastic teeth, composite overlays where I'm really doing full tooth and stuff, I really don't see why this wouldn't be possible. So I would say if you're a general dentist and you want to try to do it, like just like play with it and talk to other general dentists. I bet they got that junk. So then root canal goodness. Okay, so I also don't do this, but I have used this successfully for HVAC pulpotomies when I've had trauma situations where I end up having to do a HVAC right there chairside, right? So I don't see why it wouldn't work to do RCT if I could do HVAC, right? Okay, so common issues with permanent teeth. Zingers again. So they're thicker. So you might want to, if you're starting it and you're noticing you're having a lot of zingers, maybe add a couple more seconds onto your comfort prep. And again, pay attention to the patient. So you're looking for the frosting. And then when you're going, if you haven't done it a lot before, just watch their body to see when they're going, whoa, that's a little weird, but it doesn't hurt yet, right? So if you need to stop, redo comfort prep, no big deal. Safe zone violation. These are real for permanent teeth. It's a little bit for baby teeth, real for permanent teeth. Because we all know those ones that you think it's just this little dot by the freaking groove, and then you get in there and it's like, wee. And you're like, cave. So then you're like, well, I didn't anesthetize that. So once I see the cave start to open, now, even if I kind of cheated wider, 100% of the time I stop, I go back to comfort prep and I do a little bit more circumference around the edge. So you're attuned to the patient, make sure they're comfortable. Don't be afraid to pick it up and do comfort prep for a couple more seconds. It's okay. Hypoplastic, hypomineralized teeth, same as we talked about for pedo teeth, nothing crazy. And then, is this thing working? So I've heard this from people that I've trained. They say, okay, when it comes to permanent teeth, I go, is this working at all? Like, is this not cutting so slow? Okay, it can take a little bit more time. So what I found is, as I've really thought about it, as I've done training, I actually stay in one spot longer on permanent teeth than I do for pedo teeth. I just kind of go, cut, go, cut, right? So yeah, just stay there a little bit longer. If it's really irritating you, what do? Turn the hertz down. You got it. Okay, so don't be impatient. Take that extra second. You can get through it. It's okay. All right, soft tissue. Woo, 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 frenectomies. No local ones. So this is what I do. Talk to other people. I'm sure everybody has their own special spice. If it's thin. So what I'm looking at, and this I've learned through time, like if it seems kind of translucent-y, pretty thin, and you feel like topical can penetrate, go for it. Go for it. Do it. What's worse that's going to happen? You're going to go, oh, I felt that. Oh, I'm so sorry. Let me use more sleepy jelly. You got it. Good job, kiddo. Or large kiddo, adult. Okay. So I'm going to tell you the 2 different methods that you can use for getting these guys numb. So a forest of cotton tip applicators. You can use just a ton of cotton tip applicators and just kind of have you and the assistants hold them. And if you can think, this is the frenum, right? Just line the frenum, both sides with these cotton tip applicators. So the pro here is you use less topical because you're being precise. The con, you have to be precise and put it everywhere where you're going. So there's the cotton plus gauze. So you can start out with those cotton tips and do it for about 1 minute of your concentrated topical. It's going to take about 2 minutes. Then get a 2x2, swipe into the swipe into the topical, and then just place it over the area and hold it for another 1 to 2 minutes. So the ones I use local on are those ones where I feel like it's just a huge thickness of surgical tissue. And I know that the outside I can get really nice and numb, but as I cut deeper, they're going to feel it. So those are the ones I end up using a little bit of local for. Gingivectomies, I very rarely use local because they're so thin. You can just topical that jump. Again, it's all good by either one of those methods. Go with how you feel. Operculectomies, you can do it. It really depends on the thickness. For really, really thick ones, I've done both. I've done two ways. So either I will local it if the patient prefers, but if they really don't like the idea of local, what I do is I do topical, and I tell them they have to tell me as soon as they feel anything weird. And so they'll raise their hand as soon as it's weird, and then I stop, retopical, and then keep going. And we do that until it's done. So yep, there you go. If you feel like it's too thick, don't worry about it, just anesthetize. And then pack and cord, the bond prep setting. So if you have that setting you do for bond prep, that's something I do in restorative as well. I go around the whole tooth. So for this, really just go around the whole tooth and then pack that cord. You got it. You do have to be careful. So what I tell people is watch your angulation and try to go as much down instead of around where you're going to be hitting the gingiva. Just kind of pack really straight down. And then they're okay. Okay, other adulty things, crown lengthening. But it'd be fun to play, right? Like I kind of like to see. I don't know. You could try it. Talk to people. Go for it. How soft tissue can go bad. Okay, this is very short. Basically, for anything, they feel something. That's really the only thing that happens. Then what can you do? Stop. Reapply topical, like we talked about for your perculectomies. Use local. Yeah, no, that's about it. So now we branch into what kind of patient populations could I do now that I can use this amazing tool? Oops, sorry. Needle phobic patients, huge market, right? There are so many people that literally avoid the dentist because they hate being poked. They don't mind your hands all up in their mouth. They don't mind other things. They just hate being poked. So this is a great market for you. High anxiety patients. So with high anxiety patients, every single thing you're doing is a big deal. So the more that you can reassure them that it's going to be a sensation they can recognize, that's what I found is with my high anxiety patients, I don't promise you're not going to feel anything because some of them really don't like the sensation of water. So what I tell them is a lot of them we've already done prophies on, right? Because they did prophies, we did diagnosis, and then they're here for treatment, right? So what I tell them is, do you remember how it felt when we used the water to get off your toothpaste? And they're like, yeah. And I'm like, okay, sorry, excuse me. It's going to sound different, but it's going to feel very much the same. Okay, I survived that. I can survive this. No shot equals greater happiness. You can analogize it to something that they don't find frightening. It's going to lower that anxiety. Special needs patients. These guys are my heart. I love them. That's the one of the big foci of my practice is special needs patients. So what kind of special needs patients? Girlfriend, what kind of not special needs patients? Everybody, right? Autistic patients, verbal autistic patients, nonverbal autistic patients. I have people again that I meet that I'm talking to about my laser and what I do, and we were just chit-chatting, and they'll be like, you do nonverbal autistic patients like doing Resto? And I'm like, heck yeah. And I guarantee I'm not the only one, but this is my story, so I'm gonna tell them. Downs patients, yes, absolutely. CP patients, so many different kinds. You know, kids with genetic anomalies, like all these kids, you can do it. A lot of them, if you can break it down into small chunks and you can say that you're not going to have to use anything super stimulating, they got that junk. Okay, so tiny people, I kind of referenced this earlier. Oh my goodness. They're some of my favorites. They're like super adorable. I had this one kid last week, super cute. We did 2 occlusals, and then he has ENF. He has 2 anteriors. So we did both occlusals. We got through one, and we're going to do the last one here pretty soon. And every time I see him, he's 2.5. He's super cute. Every time I see him at like his reward, what I let him do in all those increments that I stop and give him breaks and let him sit up and be a person in the universe. He wants to do air water. So we've gotten really good at aiming the air into my sink. The water into my sink, so he can be like pew 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 pew. But they're super fun. They're very rewarding. It seems intimidating, I know, because when I first started, I was like, who. But you totally can. It's a great market to move into, and so many of those parents would really like to avoid heavy sedation. So if you can, you're going to find a whole new market of moms that are coming to you. Okay, all sizes people with soft tissue restrictions, those frenemy things that we all talk about. I put some pictures up there, blah, 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 frenems. Okay, working professionals that are watching their clocks, because you can do this fast. you can do this fast. It just kind of changes the dynamic of your resto appointments. So you can say, I'm going to get you in, I'm going to get all this done, and then I'm going to get you out, go. Stay-at-home parents that are watching their clocks. We know sometimes we talk about working professionals that need to watch their time. We know those moms be watching their time too. So then big cases, say you want to do like a mega appointment, you want to do tons of stuff, but oh my gosh, you're going to exceed the local. I'm assuming. So if you're doing one of those big mega appointments and you're maxing them out on local with the laser, there is no max, right? So you can do tooth by tooth by tooth by tooth by tooth and do these big smile makeovers and you can do it however long you want. So where do you want to go? That was where I put onto my learning objectives that maybe by the end you guys could be like, well, what do I want to do? Which populations do I want to move in, right? So what I would say, I'll go back up, is as this time I pass through, I would encourage everybody, write down one or two that you feel like you could actively target and could really be patients you would enjoy working with, and populations that you feel like might be being underserved or not targeted in your area. So remember, we have those needle phobic patients, we have high anxiety patients, we have special needs patients, we have little tiny people, we have all soft tissue stuff. So if you're super into frenectomies, you rock that junk out. You have working professionals that really need to watch their time. Stay-at-home parents watching their clocks. If they seem appealing to you, or that there's ton in your area and they're having trouble finding a dental home, target them. Huge cases. Do you want to do smile makeovers? Is that going to be your thing? Just write it down if you like it. So then, all right. How do I do that? Okay, now I have some ideas about who I want to target. How do I do that? Okay, first, get it? MC Hammer, break it down. So what you want to do is, what am I going to do? What am I going to do internally? What am I going to do externally in order to make this targeting of this patient population a reality? So internally, do you need to do anything different in your appointment protocols and your procedures to accommodate these patients? Do you need to change what you're doing in order to be able to handle what these patients need? Do you need to change how you're scheduling the patients from how you're regularly scheduling? Do you need to create different blocks? Do you need to put them certain places? How do you need to do that? Do you need to do any additional training for your team so that they can be prepared on how to handle these specific types of patients? And then do you need to generate any materials? Is there anything that you really feel like you would need to hand out at that new patient appointment or treatment planning if there's existing patients? Is there anything you'd want to hand out at the beginning of work? Is there anything you'd want to hand out as the work gets completed? Then externally, okay, who are you going to be targeting? And don't worry, I have an example. I'm going to go through each of these steps. Got you. General patient population. So who is it? Who are these people that you're talking about? The age range, how old are they? Socioeconomic status in general. If you're doing smile makers, you're probably not targeting people that are on a fixed income, right? Because they're not going to be able to make that achievable. Geographic location. Are you looking for the zip codes right by your office? Are you branching out? What are you doing? Where are you going? Then how aggressive do you want to be? Do you want to make this a word of mouth campaign where you're starting it and then you're counting on your patients to spread the word? Are you doing a grassroots campaign where it's you thinking of, could I talk to pediatricians? Could I talk to general dentists? Or if you're a general dentist, could I talk to, family physicians in the area? Could I talk to pain clinics? Who do you want to talk to? Print options, are you going to send out a flyer? Are you going to do, those mailers? What are you going to do? And then marketing agencies, are you going to go big? Do you want to pay people to actually really aggressively target this? So how we're going to talk about that is a case presentation of how I did this for special needs patients. Because like I said, it's a huge focus for my practice. It was something I really wanted to do when I came out of residency. So different appointment protocols or procedures, like I said at the beginning of that list. So I thought, okay, if I am seeing a lot of special needs patients, do I need to do anything different than I'm doing for the regular patients? Oh, heck yeah. Yeah, I really, really do. So what do I need to do? The fundamental idea I'm about to describe here is tell, show, do on steroids, like huge tell, show, do. So what did I do? How does that go? I broke our appointments down, the prophylactic appointment, so prophy and exam and fluoride, all those things, into little tiny chunks. And then I tried to conceptualize what are the stimulations in those and how could we slowly work our way through those stimulations in little chunks. And then I thought, well, how would we do that? Bringing back every day, man, that's a lot for the parent. Okay, how often? I looked into ABA therapy and I was like, okay, you know what? It looks like weekly to 2 weekly, those kids are going to retain. So, okay, how could we break this down into every week or two? So I'm not going to belabor this and go through it. But what I did is I went through and I made like targets, like, okay, first we do this, then we do that, then we do that. And I did it for prophies and radiographs. And once I had done it for this, I started doing it for treatment. So do I phase kids into doing treatment? Heck yeah, all the time. And then what I'm not going to talk about here, but I'll mention just quickly in passing, is that once I had done this for special needs patients for about 1.5 to 2 years, I started doing that treatment phasing for regular patients. So now I have a whole huge population of people that are sedation avoidant. They don't want to do sedation. And so they come to me because they know, they've heard from their friends, they've seen in my marketing that I will go to the wall to try and train their kid how to do this. Because to me, it's an investment in the patient, because if I can train this patient to be able to do the work, next time they have a cavity, I don't have to do sedation again, I just do it. So there you go. Wait, hold on. Whoa. If I'm going to be doing like all those appointments, say what? Isn't that going to kill your schedule? How can you make a living? Well, it would if I let it. So what do? I utilize my amazing people. So what I did when I had this brainwave is the first little bit I did it myself to kind of pilot out how it could work. And then I go, okay, my assistants. What do my assistants do in this program? My assistants are the workhorses of this program. My assistants really do the program. I talk about the program. I treatment plan the program. They do the program, which means that I have to be very selective on who I hire. I will tell you guys, hiring for me is kind of a nightmare because I'm asking a lot of them to be able to do, because they're going to have their own patients that they do. So they're assigned to a patient at the beginning of their staging journey, and they essentially become their patient. They really do. And they talk about them as if they are their patient. They introduce everything first. They're the first face they see. They're the first one introducing all the stimulations. They do it. And then at the end of the appointment, each of these staging appointments, they come and they brief me and they say, this is where we got today. And I come in like a hero and I swoop in and just repeat what they did for that day. And then we talk to the parent about what we're going to try next time. So then my hygienists, how do my hygienists work into this? So they're the skill builders. So after my assistants have kind of put out how things are really working, then the hygienists come in and they help to generalize, they help to lateralize those skills. So they are coming in, and whatever that the assistant has done, we only start this after the assistant's gone through the whole prophy. Then they come in and they start with just scaling. And then they move into prophy cup. And they'll usually start one area of the mouth, then lateralize out. And they stay with them until they can do that entire prophy. And when they can do the entire prophy, and I'm doing exam at the end of each of these appointments, then we go, okay, and we have we do it in rules of threes. So we go, okay, when you can do it 3 times in a row, we move you back from every week to 2 weeks to every month. And when you've done that 3 times in a row, when we move you back to 3 months, and we've done 2 cycles of 3 months in a row and you're fine, then we move it back to 6 months. And that's when we start trying to stage radiographs. So then front desk, what do they need to do? How do they need to do something different? So they're the master planners of this program. Very important part. They figure out how to balance the needs of our patients with, because they have a huge need for consistency. Even my just highly anxious patients who are doing this program need a huge amount of consistency. If you're popping them in and out of schedule everywhere, they will not do well. So they figure out how to help that need for consistency match to the flow of our schedule. And they also strategize with the family to make this financially feasible, because we're going to be seeing these patients longer term. Even though the program is a pretty good chunk, they figure out how they can make that workable for pretty much any family. So figuring out pricing structure, since we just talked about that, that was a huge thing I needed to do because I don't want to go broke. So as you're looking at your patient population, there's a big question you need to answer. Critical question is this a production driver, or do we just need to not lose money? For me, I just didn't want to lose money. That's it. This wasn't going to be something that I made a huge bunch off of. It was something I was doing for my heart. So what I did is I used the metric of my assistant's time. How much am I paying my assistants? And I did a high average. So I did like the most I'm paying them and added $1 or $2. And then the approximate number of appointments I would probably need for the average special needs patient. And then what about my overhead would be for that increment of time. And then that is the amount that I charge for the program. So, if this is a production driver, you would need to increase that, right? You need to make it more so that you're actually driving production with that. So you could put it in production slots, because we make sure utilizing my assistants and my hygienists, we put them in relatively non-production slots. We don't sacrifice any production slots to do it. Okay, so then training. Did I mention we should do training? Maybe we should do training. I think we should do training. Yeah, training. So for the assistants, what did I do? Training on the chunks. What I did is I explained to each assistant if I bring new assistants on, this is the idea of the program. These are the stimulations you can think about. Think it through. And here's stuff that's easy. Here's how it gets harder. Here are the things that are very challenging for most kids, whether they're just highly anxious or they're special needs. Then focused work on encouraging, incentivizing. We really work with how they're working with patients. We always start assistants in my office out in hygiene, so we can really develop their skills before we pop them back there in op and with these patients. Then we do continuous training on communication, emotional intelligence, all these things. Hygienists, training on those break points, so the hygienists know when they can stop and about how much they can shoot for. A lot of my hygienists are much more black and white people. So I go, okay, 3 teeth at a time, 6 teeth at a time, whole arch, right? Things like that. And then that same training on communication and emotional intelligence. Front desk, training on the diagnoses that we see and their need for consistency, so that they understand which ones they can maybe fudge and move a little and which ones really need to be in the same slots. And they got to find an initial slot that they can stay in throughout time. And then that same training and communication and whatnot. Materials to hand out. So I made this pretty full flyer. If anybody had talked to me at another meeting or at a training and stuff, I live on Vistaprint. I love Vistaprint. So I made this little pretty thing on Vistaprint. And then at the first appointment, I give this to my parents. If they're going to be in the room with us and stuff, I say, here are things that can promote coping. Here's things that you think are going to help and they're not helping as much. So please stay away from these. Thank you. You're doing great. So who was I interested in targeting? Now we're getting external. Who was I doing? Basically anybody that has sensory or cognitive or behavioral challenges. Yep, you. Then age range 2 to 17, because I'm a pediatric dentist. Socioeconomic status, flexible, because I have those payment plan options and because I'm not charging a premium for this because it's not production driver. And geographic location, I targeted the zip codes around my office and down the main highway from my office because I have working parents that go down to Houston. So how aggressive was I in trying to attract these patients? Very aggressive. Yes, I was, and still continue to be because I love them. So grassroots, I got into the offices of the pediatricians. I met with autism center directors. I made lots of Facebook, Instagram posts, things like that. For print, I did magazine articles. I do banners on community sites. So I have there's 2 huge community directories in our area. And so I not only am on the directory, I pay to do banners. So, and specifically about special needs and stuff. Then the marketing agency, I do Google ads, I do Facebook ads, I do YouTube ads. I have a really refined marketing machine that I plug special needs stuff into. So you ask, is it working, Leslie? Is it working? Beautifully. So I would say probably conservative estimate is about 25-30% of my patient population has some form of special needs. So that was definitely not true when I first took over the practice. So I'm a big special needs clearinghouse for our area. I love them. I do them all the time. They're my heart. And if I can create something like that, I'm just this random chick in frickin' the Woodlands, Texas, right? You can do this. You totally can. You got this. So questions. Oh, there's a baby again. Questions. We did it.
All right. Okay, we just have a couple questions we can address, and then to our audience, we'll wrap up with please stay with us because I'll give you instructions on how you get your CEUs here in a minute. So hang on. Okay, so Dr. June, hi Dr. June, good friend of Biolase. She asked, do you ever use the bond prep settings in the I plus?
All the time, literally every prep.
Okay.
So what I do is I didn't talk about it because I felt like I wasn't doing a training one. I wanted to gear it slightly different. But what I do when I'm prepping is I do that comfort prep. Again, if you want my settings, I'll send them to you, but I do it, the settings that I like, 6 watts, 75 hertz, blah, blah, blah. Then I do rapid prep. Then I pick up my hand pieces and I do high speed, low speed, do my thing. And then I go back with bond prep at the end and I redo the pulpal floor and usually a little bit of the axial walls and all those other things. And I also go right around the gingiva because I did split mouth and other things when I first started doing this on my own patient population. And I really felt like doing that decreased the amount of I got when I wedged. So that's what I do.
All right. And then the other question we had, it was about some of your market. So how can you successfully use this for hyperactive children without using nitrous oxide?
So it's kind of like, so my staging thing, as we've done it a ton, it's really bled into how we practice, like how I'm physically doing dentistry. So I do a lot of anxious kids. I do a lot of other kids. And basically, what I do is if I know that they can't stand having, because I use isolite with everybody, right? 2-year-olds, I'm using isolite. So when I have the isolite in and I know that they can't take it for that long, I count. So what we do is when we're staging them, we build their ability to tolerate for a count. And usually when we're done staging for treatment, or if we're not staging and we're trying it, a lot of times I send isolite home with the parents so they can try it before they come back for the op appointment. And I roll that into my restorative costs. You can talk to me about it. But what I do is we're building time. So if the kid will initially tolerate 10 seconds, we're pushing to 15 or 20. But if they can only do 20, okay, I'm working in increments of 20. And we better believe my lovely assistant is counting slow. She's like, 1, 2, and Dr. Leslie Blackburn is like, go, 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 go. And then we take it out and we're like, oh, you're doing so good, so amazing, go great. And as I go, if I can see those ADHD kids, if I can see our hyperactive kids getting like kind of trying to time out, what I ask them is I say, hey, I could do this again for longer, or I can keep going short. What do you want to do? And I try to just get their buy-in.
Great. Gotcha. All right. Well, thank you again, Dr. Blackburn, for an awesome lecture and great content over the past hour to our audience. Let me just go through a couple details about education.biolase.com. So if you watch this webinar and you want to watch some other webinar content that we have recorded over the past couple of years, you can go to this website and find our webinar library. You can also find it by simply going to biolase.com and clicking on the education link at the very top of the home page. And if you are a current Waterlase laser user or are interested in looking at Waterlase lasers for your practice, you can hop into this website and check out all the nice education that we have in here. This is our education portal that includes courses. So we have foundational courses, but we also have advanced courses that are specific to each discipline in dentistry, all listed there. And we have a slew of courses scheduled over the course of the next several months that you can click on when you go to this area of our website. One of those being on June 10th with our good friend, Dr. Ben Curtis, who will be instructing a one-day pediatric focused course at our brand new Biolase Education Center at our corporate headquarters out in Foothill Ranch, California. Hey, if you have any questions, for Dr. Blackburn that we didn't get to that pops up in your head, feel free to email us at education@biolase.com, and our team at Biolase Education would be more than happy to help you. And again, Dr. Blackburn, thank you for your time and all sorts of energy this evening. We loved it. And to our audience, thank you for joining us. And until next time, I hope you have a great evening. Thank you, everyone.
Thank you, guys. Appreciate it.